Hello, everyone, and welcome to today's webinar, Current Controversies in the Diagnosis and Treatment of Trichomonas vaginalis and Mycoplasma genitalium. I am Sabrina Lemus of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Abbott. To learn more, visit abbott.com. This webinar is educational and thus offers free continuing education credits. Please click on the continuing education window at the bottom of your screen to obtain your credits after the webinar. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. This webinar will include multiple interactive polling questions throughout the presentation. We ask that you please participate in these as they come up. To do so, simply use your cursor to select the answer best fitting, and the speakers will be able to see your response in real time. I'd now like to welcome our speakers, Dr. Christina Muzny, Associate Professor of Medicine, Epidemiology, in Obstetrics and Gynecology at the Infectious Diseases Division at the University of Alabama at Birmingham, and Dr. William Geisler, Professor of Medicine Epidemiology at the Infectious Diseases Division at the University of Alabama at Birmingham. Dr. Muzny, you may now begin your presentation. Welcome.
All right, good morning, everyone, and thank you all for being here today. So these are my disclosures for this presentation. Research grants to my institution, salary, consulting fees, speaker and reviewer honoraria. And I just want to remind everyone that this program is sponsored by Abbott, and we are presenting on behalf of Abbott. And the content of this program is in compliance with Abbott's applicable regulatory requirements. So I'm going to start talking about Trichomonas vaginalis, and then Dr. Geisler will end by talking about Mycoplasma genitalium. So the learning objectives for my portion are to provide a brief overview of the epidemiology, clinical manifestations, and consequences of Trichomonas in women and men. Also to discuss current controversies in screening and diagnostic testing recommendations for this STI. Then to provide an overview of currently available diagnostic tests. And finally, to review the current controversies of treatment of Trichomonas in women and men. So just to briefly review epidemiology of Trichomonas in U.S. women and men, this STI prevalence has been found to be 1.8% among women and 0.5% among men in the National Health and Nutrition Examination Survey. This was first published in 2018. This was the first time that the NHANES had tested men in their study, and also the first time that a highly sensitive nucleic acid amplification test was performed for both women and men. The participants in the study were ages 18 to 59 years old. There was a very significant racial disparity with regards to Trichomonas infection in the study in the African American population, with African American women having a prevalence of 8.9% and African American men having a prevalence of 4.2%. Other factors associated with Trichomonas were older age, less than a high school education, being below the poverty level, and having greater than or equal to 2 sexual partners in the past year. With regards to epidemiology of Trichomonas here in Alabama, where Dr. Geisler and I are, we have a very busy health department, public health clinic, and this clinic actually initiated routine screening for trichomoniasis among all women and men coming to the clinic in 2012, so almost over a decade ago. We looked at the first year's worth of data based on nucleic acid amplification testing on these patients. We found the overall Trichomonas prevalence at our clinic was 20%, so very high. Actually, when you stratified by gender, it was 27% in women and 9.8% in men. The lower prevalence in men, although it is higher than the national average, may be due to spontaneous resolution of Trichomonas in men, which can occur in some men, but the host and parasite factors associated with this are not poorly characterized. Importantly, in this study, Trichomonas gnat detected a third more infections in women than if wet mount alone was performed. With regards to clinical consequences of untreated Trichomonas infection, in men, it can cause non-gonococcal urethritis, penile discharge, dysuria. There's also a known increased risk of HIV infection, infertility in men, and then there's questionable data, some for and against, whether or not Trichomonas increases the risk of prostate cancer. In women, Trichomonas is associated with multiple adverse outcomes, including vaginitis, cervicitis, endometritis, and an increased risk of post-gynecologic surgical infections. In addition, multiple studies and meta-analyses have found that Trichomonas increases the risk of adverse birth outcomes in women. Similar to men, there's also an increased risk of HIV acquisition. For women, there is a known association with an increased risk of HPV, human papillomavirus infection, and cervical cancer. This has been noted in a meta-analysis of multiple studies looking at the risk of Trichomonas and cervical cancer. Also in women, it can cause infertility and fallopian tube damage. However, despite its high prevalence and multiple adverse clinical consequences, Trichomonas right now in the United States is not nationally reportable. There are currently no established screening, surveillance, or control programs for women or men. Routine screening right now is only recommended in HIV-infected women at entry to care and annually. Screening can be considered for persons in high prevalence settings such as STI clinics and correctional facilities, and also for asymptomatic persons at high risk. Those would include people with multiple sexual partners, people engaging in exchange of sex for money or drugs, people illicitly using drugs, or people with an STI history. Why do we not have Trichomonas being a reportable sexually transmitted infection in this country? Apparently, you have to meet all 7 criteria to be a nationally reportable infection. A paper was written about this over a decade ago now, stating that Trichomonas only meets 3 out of 7 of these national criteria. With regards to it meets frequency, being a common sexually transmitted infection, it meets the criteria of having associated disparities and adverse health outcomes, as I have outlined on a previous slide. And it also, communicability, we know that it is a sexually transmitted infection. However, the other 4 criteria, severity, associated cost, preventability, and public interest, have not been met by Trichomonas. However, these criteria, the rationale for this was published 10 years ago now, and these other 4 criteria are very controversial now, which I'm happy to talk about that at the end of the presentation if there's any questions about this. So right now, not all successful STI control measures are being used for trichomoniasis. We have very sensitive screening tests and diagnostic tests, which I will briefly overview later on, particularly the highly sensitive nucleic acid amplification test. We also have availability of very effective, affordable medications, which metronidazole is the most commonly used medication for trichomoniasis, and it is the most affordable treatment for any STI in this country. Accurate reporting of cases, however, is not available, nor is mandatory reporting to the CDC for Trichomonas, as it is not a nationally reportable disease. We also have expedited partner therapy of treatment of infective sexual partners. This is permissible across the country except in 4 states right now, of which Alabama is one of them. However, in history, though, EPT has mainly been used for treatment of sexual partners for those with chlamydia and gonorrhea, and data on its use in the real world for trichomoniasis is minimal. With regards to clinical manifestations, there are multiple symptoms and signs that Trichomonas can cause. However, it is important to note that infection may be asymptomatic in a proportion of patients. For those who are symptomatic, it can cause women having vaginal discharge that gets worse during their menstruation. It can cause genital itching, dysuria, and dyspareunia. For men, it can cause a penile discharge and also dysuria. Signs in women can include vaginal erythema, a yellow-green frothy malodorous vaginal discharge, which the picture on the top shows that vaginal discharge. It can occasionally cause what's called a strawberry cervix, which are punctate mucosal hemorrhages in the cervical epithelial cells. Also, with regards to the vaginal pH, it can be elevated in trichomoniasis, but importantly, it can also be normal. So this brings us to our first case in my section. This is a 30-year-old African-American woman who presents to the clinic with worsening vaginal discharge over the past week. She reports a new male sexual partner who she met on a dating app, Bumble, a few weeks ago. They have been having unprotected penile-vaginal sex and oral sex. She has a Mirena IUD that has been in place over the past 6 months, and she has not had menses during this time. She cannot remember when she last got screened for HIV or STIs. A pelvic exam is performed on her in clinic, in which she is found to have cervical discharge that is pooling in her posterior vaginal fornix. There's no uterine or adnexal tenderness. Her IUD string is visible. There is mild bleeding occurring with cervical specimen collection for STI testing. No other abnormalities are noted. Her vaginal pH is found to be mildly elevated at 4.7. Her wet mount had no clue cells, no trichomonads noted, many white blood cells, and several red blood cells. Her whiff test was mildly positive. Her KOH smear did not show any yeast, and her urine pregnancy test was negative. So for our first poll question today, what additional tests would you order at this time? So everyone can start putting their answer in on this, and we will view the results in just a few seconds. I will read through the choices quickly. Would you get an endocervical NAT test for chlamydia, gonorrhea, and trichomonas? Would you get an endocervical NAT for chlamydia, gonorrhea, trichomonas, and Mycoplasma genitalium? Would you get an endocervical NAT for chlamydia, gonorrhea, trichomonas, and also get a blood test for HIV and syphilis? Or would you not order any additional tests for her at this time? So please include your polling results. I am seeing a few responses right now. I will give you all a few additional seconds for people to continue entering their results. All right, so it seems like we have a mixture of responses. So I'm glad that no one is picking would not order any additional tests, because that definitely is not the right answer. So the correct answer here is what the majority of people are picking, which is the endocervical NAT for chlamydia, gonorrhea, trichomonas, and getting a blood test for HIV and syphilis. That is the correct answer. The one right above that includes Mycoplasma genitalium testing is not correct. And Dr. Geisler, in his portion of the presentation, will tell you why this is not correct, and this is currently controversial. All right, moving on to our next poll question. What treatment would you give this patient now? You can start putting in your responses. Would you give her a shot of ceftriaxone and doxycycline? In the first answer, B, would you give her ceftriaxone plus doxycycline plus 7 days of metronidazole? Would you just give her metronidazole only for 7 days, or would you not give her any treatment at this time and wait for your test results to come back? So I'll give everyone a few seconds to put their answers in. All right, so a lot of people actually want to give this lady metronidazole. However, right now in real time, the correct answer is actually the first one. So that correct answer is ceftriaxone and doxycycline, because this lady does have cervicitis, which you have determined based on her physical exam. I know we're in a Trichomonas lecture right now, and so everybody's going to want to give metronidazole. However, so far we don't have any evidence that she does have Trichomonas infection. So to follow up on this case, she was empirically treated for cervicitis with answer A per current 2021 CDC STI treatment guidelines. Given the presence of blood, it was unknown if her borderline elevated vaginal pH and her whiff tests were truly positive because no clue cells or trichomonads were seen on wet mount. Thus, originally she was not treated for BV or Trichomonas. However, her STI test results came back 1 week later and were positive for both chlamydia and trichomoniasis. The clinic had difficulty contacting her, and she did not return for treatment of Trichomonas until an additional 1 week later. So I will say, for all of those of you who picked metronidazole in the prior question, that actually is not a wrong answer. Everybody did have high suspicion of Trichomonas in this case. However, remember that wet mount only detects about 2/3 of the infection. The sensitivity of wet mount is between 44 and 68%. And for this patient, it did not detect the Trichomonas that this woman had that she was infected with. So going into diagnostics briefly, the traditional diagnosis for trichomoniasis is based on wet mount and culture. So wet mount is a point of care test. You can see here on the picture on the left, which was taken by my PhD student, Keontae Graves, of a modal trichomonad that has a flagella. You will see the flagella moving. Typically, it is important to note that wet mount must be performed within 10 to 20 minutes after specimen collection, or these trichomonads will lose their viability. However, this test is not very sensitive, as I have mentioned, although it is 100% specific. With regards to culture, this is done by using an in-pouch culture media. This pouch on the picture on the right has to be inoculated within 1 hour of specimen collection. For women, it could be a vaginal secretion. Men, it could be a urethral swab, urine sediment, or semen. For men, multiple specimen inoculation of this is recommended to increase the yield of a positive culture result. Despite all of this, the sensitivity of culture is also not great, between 44 to 75%. There is another point of care rapid test that is CLIA waived for trichomoniasis. That is the Awesome test stick. This is a rapid antigen test for Trichomonas. It is only approved in women on vaginal secretions. It is not validated in men, so this cannot be used in men. It does use antibodies to detect Trichomonas protein antigens with results in less than 10 minutes. However, its sensitivity is better than wet mount and culture at 82 to 95%. Over the past decade, there have been a large number of Trichomonas highly sensitive nucleic acid amplification tests that have come down the pipeline. I have them summarized in this slide and the next 2 slides after this. There are instrument-based tests, and there are also small device tests. I will go through what distinguishes each of these tests briefly in this presentation. I'm not going to go into very specific details. The first one that came out is the hologic aptima test, which came out in 2011. This one is only FDA cleared in specimens from women. It has to be internally validated in specimens from men prior to being used. There are no real-time results on this test. The next one that came out is the BD Probe Tech QX T vaginalis NAT test. The first version of this test came out is also only FDA approved in women, has to be internally validated in men with no real-time results. They had a next generation assay on this come out in 2016, which is FDA cleared for both female specimens and male urine, but still no real-time results. Cepheid has their Gene Expert Trichomonas NAT test, which came out in 2018. This one is FDA cleared up front in both women and men and can provide results in 40 to 65 minutes on demand. The Roche Cobas Trichomonas Mycoplasma genitalium assay came out in 2019. This one is also FDA cleared in women and men. There are no real-time results. This is the first Trichomonas NAT test that also includes Mycoplasma genitalium results. Dr. Geisler is going to talk about this more during his presentation, but it is a little controversial about what settings you would order this particular test in, as currently it's not recommended to screen all people for Mycoplasma genitalium. Finally, we have the Abbott Alinity assay, which is our newest Trichomonas assay that came out in 2022. This test is FDA cleared for 4 pathogen testing for gonorrhea, chlamydia, Trichomonas, and Mycoplasma genitalium for female and male specimens. And you can get this test result within less than 115 minutes. Finally, for the instrument-free Trichomonas NAT test, there is one that is currently FDA approved and CLIA waived. That is the VISB sexual health testing device, which came out in 2021. You see a picture of the device on the right. This is a single-use point-of-care device for detection of chlamydia, gonorrhea, and Trichomonas. This one is only FDA cleared for use in women right now on self-collected vaginal swabs. Results are available in less than 20 minutes. Finally, I'm just going to talk about treatment in Trichomonas. I want everybody to be aware that the updated CDC guidelines did have a major change in recommended treatment in women. Before, it was a 2-gram stat dose of oral metronidazole for all HIV negative women, with multi-dose metronidazole only being recommended in HIV positive women. That was in the 2015 guidelines. In the 2021 guidelines, we now have moved to recommending multi-dose metronidazole for all women, HIV positive and negative. This is due to randomized control clinical trial data, which I'll briefly review in the next slide. However, due to lack of data in men, the oral metronidazole single dose 2-gram stat in men is still the recommended treatment. So this is the first time we have discordant first-line recommended treatment that is different based on gender for an STI. There is still an alternative treatment regimen for women and men, which is oral tinidazole 2-gram stat dose. So basically, the recommended treatment in women got updated to multi-dose metronidazole based on the results of a randomized controlled trial that we did here in Birmingham, also at New Orleans, Louisiana, and Jackson, Mississippi. We recruited HIV negative women into this trial over a 3-year time period. We assessed 1,028 women for eligibility in this trial and ended up enrolling 623. They were randomized 1-to-1 for a 2-gram dose of oral metronidazole versus 500 milligrams twice a day for 7 days. The primary outcome was Trichomonas infection by intent to treat, a test of cure, 4 weeks after completion of treatment. And for the primary outcome of the study, women in the multi-dose group were significantly less likely to be Trichomonas positive at test of cure compared to women in the single dose group. This was 11% versus 19% and was very statistically significant. So finally, my last comment about Trichomonas treatment. Since the CDC guidelines came out, we do have a next generation oral 5-nitroimidazole, which has become available. And this is oral signitazole, 2-gram single dose. We did do a randomized controlled trial at 10 sites across the United States for this study. This was a delayed treatment placebo-controlled study. However, everybody in this trial got treated for trichomoniasis within 6 to 12 days. We did find that oral signitazole efficacy was 92.2% in this study, and it was 100% in HIV-infected women in the study, compared to placebo of 1.5%. Based on the results of this study and also studies done in men in Europe, oral signitazole was FDA approved in June of 21 for the treatment of trichomoniasis in women and men in this country. However, a current controversy in the field is where does oral signitazole fit into the recommended and alternative treatment regimens for trichomoniasis in women and men. For follow-up after treatment, retesting after treatment for Trichomonas is recommended for all sexually active women less than 3 months after their initial diagnosis, whether or not they believe their sex partners are treated. And if retesting at 3 months or sooner is not possible, clinicians should retest whenever women next seek seek their medical care less than a year after their Trichomonas diagnosis. For my final slide, I just want to do the summary of the Trichomonas diagnosis and treatment controversies currently occurring right now. The first is that Trichomonas is not nationally reportable, although it is highly prevalent, especially in women, and has significant adverse health outcomes. I think moving forward, we need to have more data on those 4 criteria that were controversial in the past. The second is that screening in asymptomatic women is only recommended in certain at-risk groups, as I have described, yet we have all of these available NAT tests that are highly sensitive and specific, and they are in use. How is that going to be moving forward? Is screening for asymptomatic women going to be recommended in the future, particularly given all of the adverse health consequences associated with this infection? In addition, the recommended treatment regimen, as I have mentioned, in women and men is now discordant based on gender. Are we going to continue to do this moving forward? We should do treatment trials in men. How will this influence partner management going forward, this discordance? And finally, the oral signitatazole, which is now available, where does this fit into recommended treatment? So I'm going to end here and move on to Dr. Geisler's portion of the presentation about Mycoplasma genitalium. So Dr. Geisler, it is time for you to start. Thank you all.
Okay, thank you, Christina. That was great. Job well done. So I'll take over from here. I'm going to talk about Mycoplasma genitalium. And here are my disclosures you see listed here for research grants, consulting, and speaking honoraria. So the learning objectives for my talk will be to briefly give you an overview of the epidemiology and clinical manifestations of Mycoplasma genitalium. I'm mostly going to focus then on discussing the M. genitalium test, the testing recommendations, and some of the controversies in testing. And then I'm going to review antibiotic resistance concerns with M. genitalium, what the treatment recommendations are for M. genitalium, and some of the controversies in treatment. So Mycoplasma genitalium infection in recent years has been called an emerging STI, but I'm here to tell you that it has emerged and it's very significant. And so Mycoplasma genitalium is a highly prevalent STI, and I'll show you some of that data in just a minute. It's one that may cause reproductive morbidity that's similar to chlamydia, and we'll get into that. It's one that may increase your risk for HIV transmission, and there's a lot of studies published on that. It is one where antibiotic resistance is a major concern in trying to treat this infection, and we do have limited treatment options as a result. And then finally, it's one that we don't have a vaccine to prevent, and so that's a major concern moving forward with such limited treatment options. So first, how common is Mycoplasma genitalium? Well, if you look in research studies in the general population, and general population studies are ones that tend to have patients who have lower STI risk and are typically going to be asymptomatic for most patients. There have been studies published in the U.S. and the state, from the state of New Mexico and Britain and Denmark, all looking at M. genitalium prevalence in the general population. And in males, the prevalence is about 1%. In females, the prevalence in some of the older population studies range from about 1% to 2%, which is a little bit less than what we see with chlamydia. But in the New Mexico study, the more recent one, it ranged from about 4% to 6% in younger women. And it raises the point that M. genitalium prevalence may be even increasing because of its resistance. But now these were research studies. I think as Christina mentioned, and I'm going to mention it a couple of times today, there are no current recommendations for screening asymptomatic people for M. genitalium. So we don't really have observational data from routine care in asymptomatic people. But I will tell you that M. genitalium is much more prevalent in U.S. clinic populations, ones where they offer some sort of sexual health care. And so if you look in this figure, the orange color or the gold color is men. And you can see that the M. genitalium prevalence in men in these published studies ranges from about 6 to 17%. In the case of females, which is the silver color bars here, M. genitalium prevalence ranges from about 5 to 24%. So it's very prevalent in clinic-based populations, and this prevalence mirrors what we would see with chlamydia. As far as what are the predictors or risk factors for M. genitalium infection, they're quite similar to what we see with chlamydia, and that is younger age, multiple sex partners or a new sex partner, or those individuals who report being of a non-white race or ethnicity those are the groups that have the highest rates of infection. Again, similar to chlamydia. In terms of the clinical manifestations of M. genitalium infection, they are also similar to chlamydia in that men, the most common manifestation is going to be urethritis. And of men with urethritis, you will find M. genitalium in about 20 to 35%, so it's very common. However, it's fairly rare from the data that we've seen so far that you get epididymitis from M. genitalium. And studies have reported that in men with proctitis, you can identify M. genitalium, but it's fairly uncommon. In women, cervicitis is probably a pretty common manifestation of M. genitalium. There's certainly good evidence to prove, I think, that M. genitalium causes cervicitis. There's moderate evidence that's associated M. genitalium with PID as well, though this is very debated, I would say, amongst many in this field. There is, however, pretty limited evidence about M. genitalium causing either infertility or perinatal complications at this time. There's been a few studies that have associated vaginal discharge with M. genitalium as well. And I bring this up because, often patients who have genital symptoms now, females, may not get speculum evaluations anymore. They may simply just get a vaginal swab collected for a wet mount. So you might not look at their cervix to know that they have cervicitis. So if you have a woman with vaginal discharge and no obvious cause for it, and they're failing other treatments, you might want to think about M. genitalium as a cause of the vaginal discharge that's persisting. Okay, so I'm going to go back now, before I talk about M. genitalium diagnosis and treatment, I'm going to get back to the case that Christina presented to you, and we're going to take it over and go a little bit farther with this case. So this was, if you recall, a patient who had cervical infection of cervicitis. She was empirically treated initially with a dose of ceftriaxone IM and then 7 days of doxycycline, but her trick test came back positive. And so she came back 7 days later to get metronidazole. And so picking up now on this case, she did actually complete her 7 days of metronidazole. However, her vaginal discharge did not fully resolve even after the metronidazole. So she returned to the clinic for repeat evaluation about 3 days later. And that's about 17 days, by the way, after finishing her doxycycline. She tells us that she was fully adherent with all these different treatments and that she's not been sexually active since her initial visit. However, the repeat pelvic exam at this visit shows that she has cervicitis findings again. So she has persistent or recurrent cervicitis. And that's going to bring me to our next polling question for the audience. So everybody, let me know your thoughts. Should we test for Mycoplasma genitalium at this time? She's got persistent or recurrent cervicitis or not. So the answer is either what you think, yes or no. Go ahead and start your responses. So for time's sake, I'm just going to go ahead and show that it looks like most of you would test for Mycoplasma genitalium, about 97%. That is the correct answer. And that would be following the CDC guidelines, as I will go into them in just a minute. One more question for you. This is a little bit tougher. Would you give her any treatment right now? So if you give her treatment, would you give her metronidazole for 7 days? Would you give her azithromycin 1 gram single dose, directly observed? Would you give her moxifloxacin for 7 days? Would you give her 7 more days of doxycycline followed by 7 days of moxifloxacin? Or not give her any treatment at this time? All right. So a few more responses here, going back and forth. Looks like most of you would either give azithromycin 1 gram single dose at this time, or would not give any treatment at the time, which was the most common answer. But the correct answer is actually the fourth one. Yes, you would give doxycycline for 7 days and moxifloxacin for 7 days, which would be following the CDC guidelines. And so we will talk about that. All right, so first, how do we test for M. genitalium? Well, we don't use culture. It's not very useful for clinical care. It takes weeks to months to grow this organism. So what's recommended is to use the NAT test because it's much more sensitive. And right now there are 3 M. genitalium NATs that are commercially or FDA approved in the US. And those 3 are listed here. And they're different in terms of their technology, and they're also different in terms of whether they test for other certain STIs. But for any of these M. genitalium gnats, or if you're using one that might not be FDA approved, but it's available commercially, the optimal specimen that you should be testing for M. genitalium is first catch urine in men and vaginal swab in women. And in women in particular, I will say that vaginal swab is more sensitive than urine. So urine might be easier, but vaginal swab is going to detect more M. genitalium infections if, the test is on a vaginal swab. So what are the current CDC guidelines for who you should be testing for M. genitalium? Well, what the CDC recommends is that you should be performing M. genitalium testing in men with persistent recurrent urethritis or women with persistent recurrent cervicitis, such as our case here. Or you should think about it in women who have their first episode of PID. And so if you were following CDC guidelines in our case, you would test this patient for M. genitalium. CDC does not recommend that you do any routine M. genitalium screening in asymptomatic persons. And the reason why they don't recommend is that we simply don't have enough data to know whether asymptomatic infection causes any clinical disease or burden in individuals. And there could be potential harm by telling somebody that they have an infection, even though they don't have symptoms, and then you might not be able to get rid of that infection. And so, it's not a great idea to be testing for something that you're not sure is a problem, but might cause patient more problems from their worrying and taking other treatments that may or may not help them. There are certainly controversies with M. genitalium testing recommendations. I will just briefly go through here. The first is, so just imagine if you're following CDC guidelines, somebody comes in with urethritis or cervicitis, you don't test them for M. genitalium at that visit. You just give them 7 days of doxycycline. But then they come back at some point, and maybe a week later, 2 weeks later, 3 weeks later, they come back in with persistent or recurrent symptoms. And then that's when CDC recommends that you do that M. genitalium testing. You still don't even know at that point if they have M. genitalium. And so the question is, you won't know their infection status. What are you going to do? Are you going to treat them? What treatment are you going to use? And so this is a real big challenge for us. It's really would be helpful to know earlier on if they have M. genitalium or not. Okay. The second controversy is that there are a variety of STI gnats that include M. genitalium. If you're using an STI gnat to screen an asymptomatic person, and you choose one that also includes M. genitalium testing, then basically you are going against CDC recommendations and you are screening an asymptomatic person for M. genitalium. As I mentioned earlier, that leads to uncertainty about whether we should treat that patient or not. I can tell you that the patient's certainly going to probably want treatment, but is that the right thing to do? And then what if you can't get rid of that infection? How is that going to make the patient feel? And what are the concerns there? And then we don't have any FDA-cleared M. genitalium gnat tests that include testing for macrolide or quinolone resistance. And so that's a concern, right? It leads to uncertainty about which drugs we should be choosing. With that question, I chose either no treatment or azithromycin when you should have chosen doxycycline followed by moxifloxacin. But a lot of you might be nervous about using moxifloxacin. It would be very helpful if you knew whether they had a macrolide resistant strain or not. Okay, so what are the major considerations for treating M. genitalium? First of all, antimicrobial resistance is one of the biggest. And second of all, because we have limited treatments, what strategy will you choose? Will you use one drug by itself? Will you use two drugs together? Will you use one drug to lower the bacterial load and then use a second drug? So there are lots of things to think about in how to best treat M. genitalium. In the US, there are really only 3 drug classes of antibiotics that have been shown in vitro and in clinical studies to have some efficacy against M. genitalium, and that's the quinolones, such as moxifloxacin, the macrolides, such as azithromycin, and then tetracyclines, which of course doxycycline is what most of us have used. However, I'll hopefully convince you that minocycline is a little bit of a better drug actually against M. genitalium than doxycycline is. But there's other ones that are not bolded in blue here are other drug classes that either you cannot get in the US or you can get them in the US, but they simply don't have any published clinical efficacy data to give us assurance that they would actually work. So the problem is macrolides are what we used to use for treating M. genitalium for the last couple of decades, but because of the evolution of macrolide resistance, they're no longer reliable. And so we can measure macrolide resistance based on looking at genetic testing for macrolide resistance mutations in the 23S rRNA. And there's been studies looking at treatment failure rates, and one of the best ones done show that if you have one of these macrolide resistance markers, MRMs, that your treatment failure rate is over 80%. And so you should assume that if you have one of these macrolide resistance markers that you're probably going to fail treatment. And unfortunately, it's our own antibiotic practices in the US that have driven this resistance using azithromycin for so many things, other infections, treating patients that don't even have bacterial infections with this antibiotic. And so we really need better antibiotic stewardship. But how common are these macrolide resistance markers in the US? Well, there's not any federal surveillance yet for this, but I will get into that in just a minute. But there have been published studies, and they're shown here. You see this geographic map, and you see the text next to the map, that across the US, the prevalence of these macrolide resistance markers in M. genitalium infections ranges from about 31% to 94%, with the lowest rates of MRMs in pregnant women and the highest rates of MRMs in men who have sex with men. But overall, if you just average this data out, the majority of patients who have M. genitalium in the US will have a macrolide resistant strain. And then most of those will fail infection treatment with azithromycin, which is why that azithromycin 1 gram choice is not good if you don't know whether they have macrolide resistance. And there have been a lot of studies, again, looking at cure rates of azithromycin 1 gram for M. genitalium. Studies that were conducted prior to 2009, about 85% of patients were cured with M. genitalium with azithromycin 1 gram. But since 2009, only about 67% of patients have been cured. And in the most recent randomized controlled trial of treatments for M. genitalium, less than 50% who got azithromycin 1 gram were cured. And so it's, again, not a very efficacious treatment option. Which leaves us really with the best drugs we have for M. genitalium in this country are quinolones. And so that would be your moxifloxacin. Unfortunately, there are also quinolone-resistant mutations, but unlike macrolides, when you have a macrolide resistance mutation and mostly you're going to fail treatment, it doesn't, the treatment outcomes don't always correlate with presence of resistance mutations with quinolones and M. genitalium. And so there's really only one quinolone resistance mutation with M. genitalium that has been strongly associated with moxifloxacin treatment failure, and that's what they call the S83I mutation in the PAR-C gene. And there's been one study that's really been one of the larger studies to look at how common treatment failure is when you have that S83I mutation, and it was about 59% of patients failing treatment with that mutation in that one study. Overall, there's only been a few studies in the US looking at how common this PAR-C S83I mutation is, and those studies show that it ranges anywhere from 6 to 30%. So it's certainly not uncommon. And unfortunately, when you have this PAR-C resistance mutation in quinolones, most of those patients also have a macrolide resistance mutation. So in other words, they have a multi-drug resistant mutation. Here is the quinolone resistance, the quinolone treatment data. Prior to around 2013, typically up to 100% of patients would be cured with moxifloxacin for M. genitalium, anywhere from 7 to 14 days of moxifloxacin. However, below that dotted line there, you can see that since 2013, the cure rates of moxifloxacin anywhere from 7 to 10 days are only in the 60 to 80 percentile now. And that's, again, because primarily of quinolone resistance. So this is tough. I mean, if you fail macrolides and you fail quinolones, what are you going to treat M. genitalium with in this country? Well, that really just leaves us with the tetracycline drugs. And other tetracycline drugs, doxycycline is the one we have the most experience with, but we know that doxycycline does not work well for M. genitalium. Across multiple studies, the cure rates are typically less than 50%. And it's not that we're finding doxycycline-resistant strains, it's just that the drug does not work very well. However, our Mycoplasma lab in UAB, which does testing, including culture for M. genitalium, we have identified a patient recently that had a tetracycline-resistant M. genitalium strain and had increased MICs to doxycycline as well, which does worry me that in the future we may eventually see, resistance to tetracycline drugs with Mycoplasma genitalium. But I will say that doxycycline does have a very important role in treating M. genitalium, considering we have limited treatments. And what doxycycline does do is it lowers the bacterial load. And so if you use doxycycline for 7 days as your beginning of your treatment and lower the bacterial load, and then if you come in with a second drug like a macrolide or quinolone, then patients are more likely to be cured because they're not developing resistance to that second drug because you've lowered the bacterial load. So what is the recommended treatment then? Oh, before I get to that, one other thing here. I mentioned that there was not a federal surveillance program for M. genitalium and resistance in this country. However, there are several investigators, I am one of them, who are participating in a pilot project looking for surveillance with M. genitalium. It's being done in 8 different cities in the STD clinics in those cities. One of them is Birmingham. The lead one that's running the studies at the University of Washington in Seattle, and it's Lisa Manhart. And each of these 8 clinics is collecting 800 specimens each year from men and women, both symptomatic and asymptomatic, and sending it to the University of Washington for M. genitalium testing and resistance testing. We are going to be publishing this. We're going to be presenting it at an international STI meeting in Chicago in July. So you'll get a chance to hear more about the surveillance project. But I do believe we need surveillance. And my hope is that when our pilot project is up, that perhaps CDC or some other entity will pick up the funding to continue this project. So now, what are the treatment recommendations? Well, this is tough. But where we're at with treatment is really something called resistance-guided sequential treatment. And the proposal for this treatment is that when patients first come in with a clinical syndrome like urethritis or cervicitis or proctitis that you are concerned about M. genitalium being a cause of it, then you go ahead and do M. genitalium testing at that very first visit, not waiting like the guidelines say to that second visit when they come back. But test them at the first visit, give them the doxycycline for 7 days. And then after they complete the doxycycline, look at the test result for M. genitalium that you collected. If it's positive for M. genitalium, then look at a macrolide resistant test if you have one. And if it's macrolide sensitive strain, then after you finish the 7 days of doxy, then go ahead and give extended azithromycin 1 gram on day 1, and then 500 milligrams for the next 3 days. And the reason why we use longer M. genitalium is because the bacteria just grows a lot slower. If you use only 1 gram of azithromycin on day 1, patients are just more likely to develop resistance on that treatment. But if the patient does not have a macrolide resistance marker after you finish the doxycycline, then you would want to, if they do have a macrolide resistance marker, then you would want to use moxifloxacin for your next treatment for 7 days. Outside the US, some patients may use a drug called citalfloxacin, a different quinolone. But I just told you that none of the FDA cleared assays have macrolide resistance markers, okay? So I'm sorry, before I get into that, one other thing. So how well does this sequential treatment actually work? It's been looked at in 2 different studies in Australia. And in these studies, they included both women and men, including men who have sex with men, where macrolide resistance markers are very common in both studies, almost 70%. What they found is that basically if you use doxycycline for a week, then if you don't have a macrolide resistance marker and you use a macrolide, it cures about 95% of patients with M. genitalium. If you use doxycycline and the patient has a macrolide resistance marker, and then you use a quinolone, about 92% of patients are cured. And these studies were not directly comparing sequential treatment to monotherapy, so we don't have that data. But these sequential guided treatment studies do suggest that this is a good approach. But as I was just saying, in the US, we don't have macrolide resistance markers. So CDC does recommend that sequential approach, taking into account macrolide resistance. But if you don't have access, like most of us in this country don't have access to macrolide resistance markers, what does the CDC recommend that you do? What they recommend is that, assuming a patient's not pregnant, you give them the doxycycline for 7 days, and then you just go straight to moxifloxacin. You do not give them azithromycin because, again, the majority will have macrolide resistant strains in the US, and most of those will fail treatment. So after 7 days of doxy, go directly to moxifloxacin for 7 days. And that's why the question that we asked you earlier, that's why this was the right answer, not azithromycin, not holding treatment, given doxy for 7 days, and then moxifloxacin for 7 days. So I said that there are no FDA-cleared M. genitalium tests that have macrolide resistance markers. That's true. But our Mycoplasma lab at UAB actually does have a validated assay that does have macrolide resistance markers. It is commercially available for routine care. So if you want to use the test, I know this is some shameless promotion, but you can go to our website here, or you can just Google us, UAB Mycoplasma Lab. We can do that testing at the time if you want to test for macrolide resistance markers. So I'm just going to wrap up here my last couple of slides. First is there are clearly controversies in M. genitalium treatment recommendations. I've already alluded to some of these, but let's just quickly go through them. First of all, if patients are initially treated with doxycycline for 7 days, but you're not doing that M. genitalium test at the first visit, you're doing it at the second visit, and then that test comes back positive, say a week or more later, is there a certain time point after you finish that first week of doxycycline that you need to repeat the doxycycline again, or can you just skip straight to giving them moxifloxacin? And there's no guidance in the CDC guidelines for this. There's no published studies about what to do in this scenario. But as an expert in this field, my recommendation is that because the bacteria is so slow growing that if it's been less than a week since the patient's finished that first week of doxycycline, you can just go straight to either the macrolide or the quinolone, depending upon if you have macrolide resistance testing. But if it's been longer than 1 week since they finished that doxycycline, and now you're going to treat them for M. genitalium, then I would repeat the 1 week of doxycycline to lower that bacterial load again, and then come in with, again, either a macrolide or a quinolone, depending upon whether you have macrolide resistance data or not. I already mentioned that there's no published data comparing sequential therapy to monotherapy. So we're basically we've just adopted this in the CDC guidelines because this one study, or two studies, showed that the outcomes look better with sequential therapy compared to what we saw in other studies with monotherapy, but we don't have a direct comparison, and we really need that. Another controversy is, how do you treat a pregnant patient with M. genitalium infection? And you know, the long and short of it is we don't know the right answer to that. Really, the only drug we have in the U.S. that's safe to give a pregnant woman for M. genitalium that has any published efficacy is azithromycin. But, you know, you're not often going to have macrolide resistance results. And even if you did, even if it was macrolide resistant or not, you probably would still use azithromycin. But how long do you need to treat them? Do you need to do a test to cure? What happens if it doesn't go away? We don't know the answers to those questions right now. Another controversy is, you know, we only have limited drugs to treat M. genitalium. And let's say a patient is clinically cured where all their symptoms go away. Do we need to do a test of cure, a microbial test of cure, to make sure the infection is gone? Because these drugs, again, don't work great, and resistance is an issue. But, you know, we just don't know the right answer. Right now, we don't routinely do a test of cure in patients who symptoms have resolved. And then the final controversy I want to mention is that if a patient with M. genitalium has failed a macrolide treatment combination and they failed a quinolone treatment combination, what are you going to do? Like, you know, what's your salvage therapy at this point? And so I do have some suggestions there. It is controversial, but I've summarized them on this one slide here. And that is, what we would typically do is we would give them minocycline for 14 days. And minocycline is another oral tetracycline. It's very old tetracycline. And, you know, we've had pretty good anecdotal success with this. And there was actually a published study of about 35 cases of M. genitalium where they gave them minocycline for 2 weeks, and they cured about 71% of those patients. And it's very affordable. And so I think that's a good thing. There are two other drugs. One's a metacycline, which is a newer tetracycline, and the other is lefamulin, which is from a drug class called pleuromutilins. And these are two newer drugs that do not have an FDA-approved indication for treating M. genitalium. And so it would be off-label if you're using those two drugs. Both these new drugs in vitro in the laboratory look like they should have good activity against M. genitalium, but neither of these new drugs have any published efficacy data in humans for us to have confidence that they're actually going to work. And these drugs are very expensive. Both of them are over $2,000 for 7 days of treatment if you don't get insurance to cover them and you have to pay out of pocket. And so these are not great salvage treatment options, but they are available in the U.S., okay? There are a few other drugs outside the U.S., but you just can't get them in this country. So I knew we were going to be running short on time, so I didn't put a summary slide here. I'm going to just really say thank you to everyone for attending today, as I know Dr. Muzny thanks you. If you have questions for either of us after the presentation today, you can put them in the chat, as you've probably been doing, or you can unmute your line to ask us if we have time for that. but you can also email us, and our email addresses are right here. Again, thank you so much.
Thank you, Dr. Muzny and Dr. Geisler, for your informative presentation. So we will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen, and we'll answer as many questions as we have time for. All right, so the first one that I see here, what about cervical swabs for MGen, or does vaginal swabs encompass that?
That's a great question. So no, I mean, vaginal swabs and cervical swabs will be collecting from different sites. The sensitivity or accuracy of the assay is actually pretty similar between vaginal swabs and cervical swabs. It's just a little bit higher for vaginal swabs. So if you're already collecting cervical swabs in your clinical practice, that's okay to use those clinical swabs for genitalium testing. It's also okay just to use a vaginal swab. Even if you are doing a speculum exam, you can still collect a vaginal swab. The point I really wanted to make is that urine is inferior to test on for women for genitalium compared to a vaginal swab or a cervical swab.
Awesome, thank you. And at your institution, what body sources do you test for trick?
Yes, for us, we are doing male urine for men primarily. We do penile meatal swabs if needed. Also for women, we do vaginal swabs. It can be done on endocervical swabs. It can be done on urine as well for women, and also thin prep pap specimens.
Awesome, thank you. And next one I have, what are the factors for an infection by Trichomonas for a woman without relationships?
Yeah, so that's an interesting question. The very large majority of the data suggests that Trichomonas is primarily sexually transmitted, so 99.9% of the time. There are a few scattered case reports of Trichomonas being transmitted by other means. However, these are a little controversial. One of them is basically pit latrines in the Gambia. There was a paper published on that of adolescent children frequently using these pit latrines as a group that were virginal, and a few of them got Trichomonas infection during that. And they hypothesized that it was where they were going to the bathroom at. That has been debated, as there's no good data to show that Trichomonas is transmitted by just sitting on bathroom toilets. There's also one case report of an iatrogenic transmission of Trichomonas from a traditional healer in South Africa that was doing pelvic exams on a patient. That's also pretty controversial. In addition to the sexual transmission aspect of it, beyond penile-vaginal sex, there's other sexual activities that occur. And it is known that Trichomonas can survive in wet, moist washcloths for up to 24 hours. So if sexual partners are using warm and wet washcloths and sharing them to, wipe their genital areas before and after sex, there has been data showing that Trichomonas can be transmitted that way, but that is a sexually associated way of transmitting Trichomonas. But great question.
Let me add one just quick thing to that too. Correct me if I'm wrong, Dr. Muzny. In my clinical practice, I've also sometimes seen women who get a urine collected in routine care and they find trick in the urine, but the women say they may not have been sexually active for years. And I do think that Trichomonas can persist in some women for years. So it doesn't have to be necessarily recent sexual activity. Is that correct?
Absolutely. So as I mentioned, there's no routine screening recommended for Trichomonas outside of HIV positive women. So, and trick can be asymptomatic. So women may have it for years. And like you said, they may see it on a UA incidentally or a pap smear incidentally. It should always be treated if it's seen.
Great, thank you. We have time for a few more questions here. Is there moderate evidence between Mycoplasma and infertility in asymptomatic or symptomatic people?
No, I mean, really the moderate evidence is actually in pelvic inflammatory disease, and that's driven basically by people that were primarily with symptomatic PID, where they've done testing on them. regarding infertility, these are women that are presenting to fertility providers or to be evaluated for infertility. Most of them don't have active kind of urogenital symptoms. And, if they've had infections, it's often historical. It may have been years ago. And so in those infertility studies, they're often using like an old Mycoplasma antibody assay to try to make a correlation with infertility, which is just not accurate. And so we just don't have many studies, and they're not well designed to look at infertility with M. genitalium.
Great, thank you. Next one I have here. Given the great disparity in prevalence between general and specific populations, would establishing a prevalence of both TVM and MGEN be reasonable first step in understanding the best approach to making a recommendation for testing in specific patients or populations?
I can quickly just answer that, and that I think, it's always a good idea to have an understanding of STI prevalence in your setting. If you don't have data, that's helpful to know because you're monitoring your own efforts to control STIs locally. But I will say, and you shouldn't be doing asymptomatic testing for M. genitalium anyway, and only in certain circumstances for TRIC, as Dr. Muzny mentioned. But I do think it's helpful to have that information to help guide, your testing practices.
Great, thank you. And last one here, do we know if TRIC self-resolves? How do you interpret a low positive NAAT result followed by a negative a few weeks later without treatment?
So there is some data on spontaneous resolution of Trichomonas in men. I briefly mentioned. These are done in studies of less than, very small sample size of men, less than 20 men in the few studies that are available on this. And we don't know what host factors can predict spontaneous resolution or any parasite associated factors that can facilitate that. The overwhelming majority of data, which there's not a lot, is available in men. I'm not really aware of any good data in women on that. We do know that Trichomonas can also persist for long periods of time. And a lot of this uncertainty is because we don't quite understand the natural history of Trichomonas in women or men. So those kind of studies are really invaluable. And I will say we did one small study here at our health department here of 40 men looking at the natural history of Trichomonas. And we did find that 30% of them resolved their Trichomonas in between getting tested by the hologic aptima NAT test and being called to come back to the clinic a week later. So 30% of those 40 men actually were Trichomonas negative at their next visit 7 days later. So we do know it is happening in some men, even contemporarily, like in the present time. We just don't know exactly why yet, which is an area of future research.
Awesome. Thank you guys so much. So thank you, Dr. Muzny and Dr. Geisler. Do you have any final comments for our audience?
No, I've actually been looking. There's some other questions we didn't get to, but quickly, urine or urethral swabs for M. genitalium doesn't make a difference. Equal sensitivity on those. And there's no reimbursement for M. gent resistance at this point in the U.S. There's no assays that have it. So I think the point about M. genitalium is it's an evolving field. I think there's controversies based on what CDC is recommending for diagnosis and treatment. I definitely encourage you to keep your eyes open for newer studies coming out in M. genitalium, and I suspect that there'll probably be updated CDC guidance before the next guidelines would come out in about 5 years because the field's moving so quickly with M. genitalium.
Thank you again, Dr. Muzny and Dr. Geisler, for your time today. Sorry, go ahead.
Oh, I was just going to say a few last words for the few last questions in here. Thank you all so much. We really appreciate all of y'all's questions. Trichomonas is not part of the normal vaginal flora, so it is an STD pathogen. So anytime you find it, you absolutely want to treat it. I can't emphasize that enough. And also for somebody who made a comment about a geriatric patient having Trichomonas, that's a very sensitive, vulnerable population. Obviously, you do want to make sure there's not elder abuse going on. if you are diagnosing sexually transmitted infections in elderly people. But again, for Trichomonas, because there's no national screening recommendations, people may actually have it for many, many years and not be sexually active. So that is also a possibility, but you also want to make sure elder abuse is not going on. But thank you all so much for the presentation today. And I'll pass it back to you, Sabrina.
Thanks, everyone.
Thank you both for your time today and your important research. We'd also like to thank LabRoots and our sponsor, Abbott, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. And this webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's event. Until next time, thank you guys again. Goodbye.
Thank you.